A 63-year-old male patient presented to our clinic dissatisfied with his visual acuity. He'd undergone cataract surgery 4 months prior and had received a refractive multifocal intraocular lens elsewhere. The patient had owned a successful printing company, which allowed him to take a comfortable early retirement. Having invested in a premium IOL and hoping to limit his dependence on spectacles, the patient remained not quite satisfied with his vision after cataract surgery. At the time of his visit, the patient's refraction was 0.75 with 0.75 diopters of against the rule astigmatism in both eyes. In addition to being unhappy with his vision, this patient complained of occasional ocular dryness symptoms, particularly after prolonged tasks like reading and working with the computer. At the slit lamp, a lower tear meniscus and shortened tear film breakup time were noted. His eyelids appeared normal, without significant injection, scurf, or capped glands, but diagnostic gland expression revealed slightly opaque meibum. In order to give this patient the distance vision and improve the near vision he desired, we discussed the option of LASIK, which he strongly favored. As part of this conversation, I let the patient know that without some intervention, performing the LASIK procedure risked temporary exacerbation of his mild dry eye, with the potential to affect not only his comfort, but also the quality of his vision. With this in mind, I prescribed preservative-free artificial tears to be used as needed for a few weeks leading up to his surgery. When the patient presented on the day of surgery, he reported symptom relief from the artificial tears, and his tear film and ocular surface looked normal. So I was comfortable confirming his measurements and proceeded as planned. Here we identify the LASIK flap's edge, and we lift the flap with the superior hinge. Now with the flap protected and the stromal bed dry, we obtain centration and perform the hyperopic correction. And here we replace the flap and irrigate. In the immediate postoperative period, controlling any inflammation and maintaining patient's tear film stability were my top priorities. I instructed the patient to continue with the preservative-free artificial tears, and for inflammation control, I prescribed Lotemax gel, lotopretinol, etabinate, ophthalmic gel, 0.5%, 4 times daily for 2 weeks following his surgery.
Lotemax gel is an effective corticosteroid with a proven safety profile, including low risk of significant intraocular pressure increases, and was a suitable choice for this patient, as it is for many of my post-LASIK cases. Its gel formulation ensures consistent delivery of the drug with every dose and helps facilitate retention on the surface of the eye where it is needed. Lotemax gel also contains the demulcent propylene glycol and glycerin. It is worth reiterating that Lotemax gel is indicated for post-operative inflammation control following ocular surgery. Lotemax gel should not be used intraoperatively beneath the LASIK flap. Using Lotemax gel post-operatively for inflammation control in my LASIK patients, I have had a great experience. Indeed, this patient experienced a fantastic visual outcome with the final refraction of minus 0.25 with plus 0.25 of cylinder axis 90. He seldom has to use glasses, even for reading, and he's referred many new patients to our practice.
Indication: Lotemax gel is a corticosteroid indicated for the treatment of postoperative inflammation and pain following ocular surgery. Important risk information about Lotemax gel. Lotemax gel is contraindicated in most viral diseases of the cornea and conjunctiva, including epithelial herpes simplex keratitis, dendritic keratitis, vaccinia, and varicella, and also in mycobacterial infection of the eye and fungal diseases of ocular structures. Intraocular pressure, IOP, increase. Prolonged use of corticosteroids may result in glaucoma, with damage to the optic nerve, defects in visual acuity, and fields of vision. If this product is used for 10 days or longer, IOP should be monitored. Cataracts. Use of corticosteroids may result in posterior subcapsular cataract formation. Delayed healing. Use of steroids after cataract surgery may delay healing and increase the incidence of bleb formation and occurrence of perforations in those with diseases causing corneal and scleral thinning. The initial prescription and renewal of the medication order should be made by a physician only after examination of the patient with the aid of magnification. Bacterial infections. Prolonged use of corticosteroids may suppress the host response and thus increase the hazard of secondary ocular infection. In acute purulent conditions, steroids may mask infection or enhance existing infections. Viral infections. Use of corticosteroid medication in the treatment of patients with a history of herpes simplex requires great caution. Use of ocular steroids may prolong the course and exacerbate the severity of many viral infections of the eye, including herpes simplex. Fungal infections. Fungal infections of the cornea are particularly prone to develop coincidentally with long-term local steroid application. Fungus invasion may be considered in any persistent corneal ulceration where a steroid has been used or is used. Contact lens wear. Patients should not wear contact lenses when using Lotemax gel. The most common ocular adverse drug reactions were anterior chamber inflammation, 5%, eye pain, 2%, and foreign body sensation, 2%.